Good afternoon, everyone, and thanks for joining in. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, which is entitled COVID-19 Therapeutics, What About the Oral Medications on the Way? Just a reminder that today's session and those sessions for the rest of the year will be just 1 hour long instead of our usual 90-minute format. Next slide, please. Here are the disclosures of our speakers. Next slide, please. And the agenda for today. Next slide, please. Just a reminder that CME is being provided, so you have to fill out the survey that you'll be sent upon the completion of the webinar and attest to your attendance in order to qualify for that. Next slide, please. As we all sit in the midst of an absolutely overwhelming wave of the latest trick of COVID-19, we're so incredibly grateful today to have our regular presenter, Dr. Erica Pan, to give us the moment-to-moment information on the disease curve, the public health response, and all other things we need to know about Omicron and COVID-19 in general. And today we are extremely grateful to welcome Dr. Sarah Dornberg from UCSF to give us more updates on the outpatient therapeutics that we're adding to our armamentarium. Since we only have an hour today, we're going to dive right in. We will try to answer questions as time allows in this new shorter format, so please put them in as you have them. For our first presenter today, we welcome back Dr. Erica Pan, the California State Epidemiologist. To you, Erica.
Great, good morning, or actually good afternoon, everyone. Thanks for having me back again. Let's go ahead and move on to the next slide. And you can go to the next slide. So I'm going to try to cover a few things in a short period of time. Just wanted to, give some kind of up-to-date kind of smorgasbord of hot topics and where we are in California as far as this Omicron surge and the impact we're seeing in the healthcare. A little bit about testing, because I know obviously we're all challenged with finding enough testing, and kind of some tips on looking for testing and what we're doing around that. Vaccination and boosters update, and then of course today's focus is on therapeutics. I want to tell you a little bit more about how and what we receive and how it's allocated and distributed. And then because there's some recent updates to isolation and quarantine, just thought I would touch on that, and just also touch on schools, which is always top of mind for most of us. Next slide, please. So this is what we call our epidemic curve, and I usually show this, I think, pretty much every time I'm here, and just to show you kind of over the course of this entire pandemic. The blue line is actually the cases. So that first biggest peak was last winter, and then you can see, if you look on the right-hand side of this graph, we have actually gone just about double, actually over double of that with this Omicron surge. So for context, last January, early January was when we peaked with cases, and we saw about 60-ish thousand cases in one day, or on our average. And right now, as we look at the tests that are coming in and our cases, we have peaked around January 4th so far at about 130,000 cases. And of course, this is just PCR cases in that number. So we know there's a lot more antigen testing happening. A lot of the antigen testing that's happening in sort of work sites or schools or other places does get reported to us as probable cases, which is not in this number. And then all of this increasing home and over-the-counter tests, there are ways people can report them to us, but we're not getting that. So it's probably much higher than this number, but just to give you that perspective. The other thing I want to point out on this slide is a couple other things. So the orange curve is actually hospitalizations, right? So we see usually, as you can see from the winter surge last year, a little bit of a lag. And we're seeing that as well. And thankfully, we're not seeing as much of an increase as far as that angle of that rate of rise of the hospitalizations with this particular surge. And even more importantly, the ICU, which is the black there, is staying relatively flat here during this surge. But we're watching this closely, and again, there is often a time lag. And then deaths, similarly, often do have a lag, although you can see with our winter surge, that's the red line, and they're not to scale there, but just to so you could see the deaths. But we are still seeing a decline in deaths, and we certainly anticipate over time, just because of the sheer volume of the number of cases, we will see some deaths, but I think largely due to vaccination, other immunity, and just the differences in this Omicron variant, where thankfully we are seeing less severity. Nevertheless, it is having a huge impact on our society and our healthcare system. Next slide. And then just to people, of course, are asking, you know, how much do we know about what is Omicron or not in California? How prevalent is it? This is already outdated, especially in Omicron time. But when we look at the sequencing that we do know about, which, you know, is about probably 20% or so of what of those cases are sequenced, almost 80% as of the end of December were Omicron, and there was still 21% Delta there. And of course, there's been some regional variation. I am sure when we do our next update in the next week or so, it's probably going to be over that. And certainly a lot of healthcare systems who do the S gene target failure have been seeing over 95% in many settings of that S gene dropout, which is indicative of Omicron. Next slide. And then just quickly to show you, test positivity has also dramatically increased, also a record high for us. We're at about 22%. It's been a little bit steadier at 21 to 22%. And it's hard to see on this graphic, but the testing volume is even higher than it's ever been, and we're still having that high of a test positivity. But again, it's starting to be relatively stable in the last few days. I mean, you can just see how dramatically the cases and case rates have increased just since, you know, right before Christmas to now, you know, over 10 times higher on both. Next slide. And then what else is sort of different or the same compared to last winter's surge? So we are seeing really huge increases in ED visits, and many of you have seen, and there have been many media coverage and healthcare systems saying, you know, please don't go to the ED for testing, really trying to encourage people with mild illness to, you know, stay home or do phone consultations. But we are seeing, you know, near crisis levels of ED overcrowding in certain areas, increased offloading time in many areas as far as EDs. And so this orange line here is overall ED visits, and they did not increase as much above baseline when we had our winter surge last year, when you see the blue line, which was COVID specific ED visits. But now we're seeing, you know, the COVID specific ED visits increase, but the overall ED visits are just much, much higher here. So that's been causing a huge stress on our emergency rooms. And part of the emergency rooms being full as well is with healthcare staffing shortages on the inpatient ward. It's harder to admit patients, and if you don't have enough nurses to take care of those patients, so there's a lot of backlog in the ED as well. And then that's decreasing the, or increasing the offloading times from the EMS providers. Next slide. And then this is another way of looking at overall total hospital census, and then the COVID specific. So to orient you to this graphic, the orange line here is total hospital census and total admitted patients. So last winter, we peaked out at about 53,000 patients in the hospital at the peak of everything. And that, you know, absolutely stretched our system, especially again in certain regions. And then in the Delta surge, we got close to about 50,000, but that was not quite as high. And now we are around 51,000 again. So we're getting close to that peak in the winter surge. And then the gray line here is the non-COVID patients. So you can kind of see basically hospitals have been able to offload their non-COVID patients somewhat during these surges. And of course, last winter, just people were staying home more in general. There was not a lot less interaction, a lot less of other, you know, trauma and other things with people not being out and about. And so there was a lot more offloading as we saw this increase. The blue line is COVID specific patients. And then similarly, there was a little bit of decrease in non-COVID as we had a Delta surge in this past summer. And then now again, you can see the COVID patients increasing. And you're seeing that total census increasing. So I know there are a ton of questions about, you know, but how many of these patients in the hospital that are listed here as COVID are hospitalized for COVID because they're sick with COVID, or were they tested upon admission and just happened to be positive? We are looking at that with some larger healthcare systems, and we've seen all kinds of numbers. We'll try to look at some more consistent data we get that has a huge data lag, but this is also just a decent proxy to look at. You know, even if all of these increases in COVID positive patients are, you know, if there's a large proportion that are just incidental findings, we're seeing our total hospital census increase again, and that is concerning again as far as stretching. And we have a lot less staffing than we did last winter, on top of a national shortage of healthcare providers as well. So there's less traveling nurses and other resources. Next slide. And then this is just another way to look regionally at kind of the trends we've been seeing as far as total hospital census for different regions. And the lower right-hand corner is the California. And again, seeing that we're kind of increasing right now, potentially on our way to getting as high as last winter for total hospital census. Next slide. And then another way we kind of look at things closely, and some things that are reassuring, the percent ICU availability is something we've been watching really closely, and we made some of our regional stay-at-home orders last winter based on that, and that has been you know, relatively reassuring. We had, and even during this Delta surge, what we were looking at was in areas or facilities that had less than 10% ICU availability. That was really kind of a concerning trigger. And San Joaquin is down to 16%, but they had been hovering at 10 to 11% for a very long time during the Delta surge and have been improving. They're starting to see some decreased availability again. And then here's where you can see, as far as these different regions, in most regions except the Bay Area, 21 to 23% over their baseline utilization as far as overall hospital census. And then what percent of those, again, are in the hospital? It's ranging anywhere from 11 to 22.5%. And in California, because Southern California is our biggest population, and that's where we're seeing a lot, around 19.4%. And in some of our prior kind of looking at triggers or indicators that were concerning, when we got close to 20% of our inpatients that were COVID positive, that was when things really started to surge and cause a stress on the system. Next slide. To shift gears a bit, I know there's a lot of questions on, you know, testing capacity. We've been testing, you know, it's been something like over 500,000 PCR tests a day in the state. And again, a lot of other antigen testing happening on top of that. Probably anywhere from 8 to 9% of overall testing is antigen testing. During December, it dropped a little bit, but a lot of that is probably due to schools being one of our biggest sites with antigen testing, and they were out for at least part of December. But there are over 6,000 state testing sites. And 90% of our population actually lives within a 30-minute driving distance of a state site, but you know, also acknowledging that the hours are not always convenient, but we have done a lot recently and are continuing to look at ways to increase staffing and hours and lanes in all of these state sites, especially in areas of highest need. You may have heard also about schools testing. We distributed over 10 million tests between early December and now to schools. And then just in the last several days, we've also activated the National Guard to support additional OptumServe testing sites throughout the state, and really increasingly looking at other options to increase capacity and availability, and also to offload, again, EDs in the healthcare system. There is a website. This link is not the most user-friendly one, but we'll send one later with the COVID-19 testing website. It has a way you can click on it, put in your zip code, and then find out where there are different, at least community testing sites in your area. Next slide. Oh, and this is kind of a snapshot of what that looks like. So it says find a testing site, you can put in your zip code, and then it'll show you state or other community testing sites that are on there and more information about their hours, and also a way to call or look directly at what's there. Next slide. And then just a quick snapshot on where we are with vaccines and boosters. I'm really happy to share that of our over 18, we are over 50% boosted. So that is actually quite exciting and a good landmark. We need to do more. We still need to get more people boosted. We're, of course, certainly seeing with Omicron that is really important to get that booster dose. Almost 69% of our over 65-year-olds are boosted as well. So again, encouraging data there. Still need to continue to move that dial. And then where are we in the pediatric vaccines? Since those were later to be approved, we are at 63% of the teens, 12 to 17-year-olds, and actually we're up to 20% of 5 to 11-year-olds now are fully vaccinated. Another 30% are on their way. We are not quite, since 12 to 17-year-olds, we're just approved tracking that yet, but we'll of course add that to our data sources. And then you can just kind of see the trend here. The green bars are the boosters, and that's been a big proportion of our vaccinations in the last several weeks. Next slide. And again, the topic of the day is therapeutics. So wanted to give you kind of a state perspective on this. And this, unfortunately, very scarce resource right now. We do think this is going to be a game changer moving forward when there's more supply. But next slide. But here's kind of a layout, and I apologize, this is still a relatively busy table, but I just want to highlight some things here. And again, you'll have these slides. Dr. Dornberg is really going to focus on all the clinical aspects of the differences between these products and the routes and kind of the pros and cons about them. But just to give you a sense again from a state perspective, these 4 products are all currently allocated and distributed by the federal government to the state. And then what we do is we allocate them either to counties for sotrovimab, the monoclonal antibody, and for the 2 orals, those are also allocated at the county level to the medical health operational area coordinator, which I'll explain a little bit more of that in a moment. And then Evusheld, the kind of pre-exposure prophylaxis for immunocompromised, that is being allocated to regions, to mutual aid regions. We very much, similar to our vaccination rollout, when that was a scarce resource, wanted to have an eye to equity. So the way we've been trying to allocate and look at these distributions, again, of a very scarce resource, is looking at new cases within the last 7-day averages and new hospitalizations, but also then looking at, so that's what we've been doing for the sotrovimab, for the monoclonal antibody that's still effective against Omicron. And then for the orals, we also weighted half of the weighting to the Healthy Places Index. So again, this is similar to what we did with vaccines, where we wanted to give a higher proportion where we were seeing the most cases, which is in our least Healthy Places Index, our least advantaged communities. So we've done kind of a 40, 30, 20, 10 allocation, where 40% to the lowest Healthy Places Index with the least advantaged communities again, and that's where we do see the disproportionate number of cases and hospitalizations and deaths. And then Evusheld again is actually distributed to the region, because knowing that it's both scarce and there are a lot of regional referral centers for patients that are immunosuppressed. So that is the current scheme. We have been starting to convene with some academic partners and others to really continue to think through how we can make sure that these products are getting to the communities we need them to. But you can see here in the right-hand column how little we are getting for a state this size. These are just very scarce resources right now, unfortunately. So we just within January 3rd and January 10th, not even 10,000 doses or courses, courses for all of California. And you've seen we've had cases in the 100,000 per day range. So we really don't have enough of these treatments quite yet, but thankfully they are, coming. We're hearing that as far as the orals, so Paxlovid and Molnupiravir, that supply will hopefully increase, although it may not really be ramping up until March. It's kind of what we've been hearing. And again, a very small number, initially about 6,000 courses of Paxlovid, and then another new allocation yesterday of a little bit over 9,000 courses for the whole state. And then we have a little bit more of Molnupiravir, but you'll hear some of the caveats of that when Dr. Dornberg speaks. And then again, Evusheld, still very, very small amounts, less than 15,000 courses for the whole state over the last couple weeks. And these allocations, some of them are only every 2 weeks, and some of them are going to be weekly. So we are doing our best to work with, again, our local partners and other partners to get this to places. The Medical Health Operational Area Coordinator is a combination basically of an EMS director and health officer. So if you locally, actually go to the next slide, please. Actually in a moment, I'll talk about how you can sort of look to see where you could find it in your region or community. This is just a graph to show you of the products we've been receiving from the federal government and allocating for outpatient treatments, the trend over time. And again, only these 3 products that are currently available as far as treatment that are active against Omicron over the last several weeks. And we have just gotten these larger amounts of Molnupiravir, but the others that are the most effective are quite scarce right now. Next slide. So this is just sort of a little algorithm to, as you as a clinician are seeing a patient, you can evaluate them if they're a candidate based on NIH treatment guidelines about their eligibility as far as being high risk for severe disease and whether or not oral versus IV. And again, Dr. Dornberg will give a lot more context from a clinical perspective. But once you know which of those you're pursuing, there's different lists that we have of which pharmacies or centers have oral antivirals, and then the federal HHS is providing a kind of therapeutic finder that will have locations and date of last order. They are trying to make this more nimble and more user-friendly like vaccine finders, but this has definitely been a rapidly moving area as well. And it's far from perfect right now as far as being able to, not only is it scarce, but trying to have the right information so that people can find these. But it is getting better, I think, both between the federal website on this, and then we're kind of locally in California also trying to make sure we supplement that as we can with other information about where to find these things locally. Next slide. So these are just some snapshots and the links to the different links on where to find out where and which locations have these different therapeutics. And again, consulting your local health jurisdiction as far as where and how they're allocating is also the other way to find out what's going on in your area. Next slide. And then really quickly, I know there's been a lot of changes and there probably will be, just like everything else with this pandemic and Omicron, but the most recent isolation and quarantine for the general public that we posted is or updated is January 8th, and the isolation periods have been reduced to 5 days instead of 10, but we of course want to make sure everyone ideally tests after day 5 to make sure they're still that they have cleared, and to continue to mask around others is one of the most important things for a total of 10 days, especially in indoor settings. And then people who need to quarantine are either unvaccinated or under vaccinated. And then people who don't need to quarantine are boosted, or if they were recently vaccinated, not yet eligible to be boosted based on time period. So there will be ongoing updates on this. And then as far as workplace settings as well, if people are kind of in that period where they're vaccinated or had their primary series but not yet up to date with their booster dose, they're not required to be excluded from work if they can get a test within 3 to 5 days after last exposure. And that's not applicable to healthcare personnel covered in an AFL, which is the next slide. So we also issued an update to one of our AFLs over the weekend. We've been hearing a lot from all of you in the field and for healthcare and hospital systems about critical staffing shortages. So facilities certainly should have exhausted all efforts already to bring in additional staff and modifying any non-essential visits and procedures to really maximize their staffing. But if facilities still have critical shortages, then there's a temporary flexibility that's allowed on isolation and quarantine and exclusion from work, where asymptomatic contacts can return with less than 5 days without quarantine and without testing, and asymptomatic cases can return to work less than 5 days without isolation and without testing. Again, if there are these critical shortages and if all these other things have been exhausted, this is allowing flexibility, certainly not required. And if you have adequate staffing, you should still use the usual routine isolation and quarantine rules. The other caveat here too is making sure that healthcare providers, if they are coming back early, that they're wearing an N95 respirator, both for source control and for their own protection. Next slide. And then finally, just one last kind of, again, a nod to how important it is to all of us around safe and successful schools. And we know this is a challenge right now, again, with staffing shortages in schools and just lots of community transmission. So this is where we really want to continue to support the indoor masking requirements and good fit infiltration, really upgrading your mask and your child's mask, and you're encouraging your patients to do that. We are literally updating, as we speak, a little bit better guidance for kids on fit infiltration. So hopefully that will go up very soon on our website, and we'll be able to provide links and a one-pager on that. Continue to support vaccination, especially boosters now for our teens, and getting more 5 to 11-year-olds vaccinated. And of course, ventilation, and educating families and communities about all of the important mitigation efforts to try to slow transmission. And responding to cases and exposed contacts and testing, we know has been incredibly challenging in the school setting. We're really working with school partners to hopefully update some of our guidance to, again, try to continue to balance the safe and successful schools. So stay tuned on that. We're hoping to make more updates soon to make this more doable and really support schools. And again, lots and lots of testing resources, but we know it's not enough. And then these are just some resources. And I think, next slide, I think that is my last one. Next slide, I think that's it. Okay, thank you.
Thank you so much, Erica. It's really remarkable how you're able to put so much information into such a brief format, and I feel so much better educated after that. So, but now the suspense has been killing me as you keep alluding to her. So we're super happy to welcome on Dr. Sarah Dornberg. Sarah is an associate professor in the Division of Infectious Diseases, and she's the medical director of Adult Antimicrobial Stewardship at UCSF Medical Center. She has an active outpatient infectious disease clinic, sees inpatients on the transplant infectious disease services. I'm sure she's doing so much more in the COVID world now. She trained at Harvard and Yale before coming to UCSF, and she is here today to talk to us about outpatient therapeutics. So thank you again, Sarah, for being
here. Thanks so much for having me. You can go ahead to my first slide. So I'm going to try and make this a presentation that's brief enough to take some questions and answers. Are you able to advance to my first slide?
It sounds like we're having a little trouble with slow advancing, so we'll get there. But
okay, sounds good. Well, I will talk through my objectives as we get there. I think you've seen my disclosures. So my goal today is at the end of this talk for you to be able, you can go ahead and move on to the next slide, for you to be able to describe the importance of early diagnosis and linkage to care for high-risk patients, to understand when to use and how to prioritize outpatient COVID-19 therapeutics, to be able to list available outpatient COVID-19 therapeutics, to be able to summarize differences between monoclonal antibodies, IV remdesivir, and oral antiviral treatments, and then to be able to apply this knowledge to your treatment setting. So this, next slide. This seems a little bit basic, but I thought we would start off just reminding ourselves exactly why we're treating patients. Most of the studies have really been powered to cover prevention of severe outcomes, so meaning hospitalization, ICU utilization, and death. There are other reasons why we might want to treat patients, including the potential to decrease long-term complications, improving symptoms and getting people back to work. We are still learning about that piece. And then the potential for public health benefit. Many of these studies have looked at viral loads and are describing, whether we can decrease the viral load quicker and potentially make patients less infectious. When you are able to advance, we can go on to the next slide, 2 slides from now. I'm going to talk for a minute about who is at risk for these severe outcomes, because those are the populations that we're really going to focus on today who will benefit most from these treatments. So 81% of deaths occur in patients who are over the age of 65. So age is a very important factor. Certainly vaccine status is also a very important factor. So patients who are unvaccinated or under-vaccinated are at higher risk for severe outcomes. As we well know, the unfortunate health and social inequities that we have really placed an undue burden on certain populations, place them at higher risk for severe outcomes. And then certain medical conditions, you can go back to the slide before, thanks. I have listed a non-comprehensive list, but just want to stress, especially our immunocompromised patients, that they are at much higher risk. And then, having multiple medical conditions on top of each other is kind of a cumulative risk. So patients who have advanced age and multiple medical conditions will be at higher risk than younger patients who may only have 1 or 2 of them. So the next slide shows you the NIH tiered system for how to prioritize these scarce resources. So you heard from Dr. Pond that though it's very exciting, we now have these resources available, unfortunately, they're not enough to treat all eligible patients. So this is how the NIH has suggested prioritization. And I'm sorry, it looks like this slide got cut off here. But the first tier is patients who are either immunocompromised and thus not expected to mount an adequate immune response to vaccines. So these are our bone marrow transplant patients, solid organ transplant patients, patients on B-cell depleting agents, severely immunocompromised patients, or alternatively unvaccinated individuals who also have additional risk for severe disease. So either being advanced age or being advanced age and having other risk factors. The next tier is patients who are unvaccinated who have risks for severe disease but are younger aged or don't have as many risk factors. The third tier are vaccinated individuals who are at high risk for severe disease. So that includes advanced age plus additional comorbidities. And then the fourth tier, which remember, these are still patients who are at higher risk for severe disease, just not quite as high risk, are vaccinated individuals who may not have as high of a risk as some of the other groups I mentioned. Next slide. So I was just going to introduce which treatments are available for use. And I'm sorry, it looks like some of my formatting has gotten shifted, but this timeline goes from uninfected to mild to exposed to mild to moderate to severe and critical disease. And it just shows you what are the available therapeutics for each of these. So for prevention, we all know that the vaccines are a critical piece of preventing infection. You heard from Dr. Pan of the recent approval of tixagevimab, ciljavimab, or Evusheld, which is a monoclonal antibody approved for pre-exposure prophylaxis for high-risk patients. For the exposed patients, unfortunately, in the time of Omicron, the approved monoclonal antibodies are not predicted to have efficacy against the Omicron variant. So there is not currently a great option for those exposed patients. We're going to really focus on the mild to moderate patients who now have several treatment options, and we'll go through these in a little bit more detail. But there are 3 antiviral options that I'll talk about: nirmatrelvir, ritonavir, or Paxlovid, remdesivir, molnupiravir, and sotrovimab. You can go to the next slide. So I just wanted to hone in a little bit on a very basic demonstration of what the targets are for these outpatient therapies. So as many of you are aware, the monoclonal antibodies will bind to the spike protein and prevent the SARS-CoV-2 virus from entering cells. Sotrovimab is thought to be active against the Omicron variant because it targets a very conserved region of the spike protein, so is less liable to immune escape compared to some of the other monoclonal antibodies. Once the virus enters the cell, it uses cellular machinery to translate into polyproteins, which are then cleaved by proteases. And nirmatrelvir, ritonavir is a protease inhibitor that prevents that step. Once those proteases have done their cleaving, you have the translation machinery that's virally mediated. And then that machinery does a step that's viral transcription and translation into structural proteins, and that uses these viral RNA-dependent RNA inhibitors, and those are inhibited by molnupiravir and remdesivir, which are nucleoside analogs. And then after all that step happens, the virus goes to the Golgi apparatus and gets packaged up for release. So this is kind of a very basic scheme of how these drugs work. We can move on to the next slide. So I wanted to really emphasize that time is of the essence for these antiviral and monoclonal antibody agents. So on the left side, this is a graph that looks at children, adolescents, and adults who have SARS-CoV-2 infections. DPOS is days post-onset of symptoms, so this is in the first week of symptoms. And then they're looking at the viral load of these patients over time. And as you can see, the viral loads peak just a couple of days after the onset of symptoms and then drop pretty quickly. So the time in which the antiviral medications are going to be effective is really in that first few days after the patient develops symptoms. That's when this passive immunity and antivirals really have a role. Later on, the disease is really dictated by the immune response, and that's when the immunomodulators become much more important. So getting patients access to rapid testing who are high risk for progression is really critical as we roll out these treatments. Next slide. So I'm going to move on to talking a little bit about the clinical trials of these agents and present you some of the kind of key features of the data. Rather than showing you all 4 different trials side by side, because they're so similar, I figured I'd show you some common key features, and then we can look at the results of the trials side by side. Whoops, we've lost the slides, but some of the key features of this are the inclusion criteria included outpatients who've had a short duration of symptoms. So most of the studies included patients with symptoms for less than 5 days. The remdesivir study enrolled patients up to 7 days. They required patients who had high-risk comorbidities, all of the studies included only unvaccinated patients. All of these studies were done before the Omicron variant, and the injectable trials that I'll show you were also before the Delta variant. What we know about the molnupiravir group is that about 30% of those patients were Delta, and we don't have that information yet about the nirmatrelvir. So all these studies took that group of high-risk patients, randomized them to getting active treatment or placebo, and then they pretty much all looked for the primary outcome of a composite of hospitalization or death, and then several key secondary outcomes: death, symptoms, and viral load. You can move on to the next slide. So I wanted to go over the clinical performance of each of these agents. And it may seem random how I've presented this, but these are actually listed from left to right by the NIH preference. So the NIH has ranked these agents by preference of use. So starting with nirmatrelvir, ritonavir, this was a very large study that randomized over 2,000 patients to active drug versus placebo. And they found that only 0.8% of the patients who got active drug went on to meet this primary endpoint of hospitalization or death, compared to 6.3% of those who got placebo. That results in a number needed to treat of 18. And you can see that mortality was also significantly impacted by receipt of active agent. Some basic pros, and we'll go into this in a little bit more detail, are that it is an oral agent, so it's much more convenient. And really the major downside of this drug are the troublesome drug-drug interactions that we'll talk a little bit more about. The COMET-ICE trial looked at sotrovimab versus placebo and randomized just shy of 600 patients. And they had actually very similar results to the nirmatrelvir ritonavir, in that 1% versus 7% of patients met this primary endpoint of hospitalization or death. The number needed to treat was very similar. Again, fewer deaths in the active group, though this was a little bit less impressive than the nirmatrelvir group. The pros are that this can be given as a single dose, so it's kind of a one-shot treatment. But a major con is that it requires an infusion center, which is hard to access, hard to staff, requires significant resources, and are not available to every patient. You likely heard about the Pine Tree study, which came out just before the holidays, which was looking at a very short course of 3 days of outpatient IV remdesivir. This study also showed an impressive benefit of receipt of active drug, decreasing hospitalizations and deaths from 5.3% to 0.7%. No patients died in either of those groups. The pros of this is that the drug is actually in good supply and available, but a major con is that it's inconvenient and really challenging to operationalize for patients. Lastly, the molnupiravir study called MOVE OUT, another large study, had a little bit more disappointing results in that its decrease in hospitalization and death went from 9.7% to 6.8%, requiring a much larger number needed to treat. It did also impact mortality. As you can see, 9 patients in the placebo group versus 1 in the active therapy group ultimately died within 30 days. Like nirmatrelvir, it's oral, and really its major cons have to do with its mutagenicity and lower efficacy compared to the other agents. You can go ahead and move on to the next slide. So I'll talk a little bit about some common features of how these are authorized, and then we'll go into some of the details of each of these agents. So just to remind you all that an EUA is authorization for use of an unapproved medical product to treat a life-threatening disease when there's no adequate available alternative. So all of the agents that I just presented have EUA approval except for remdesivir, which is FDA approved now, but outpatient use is considered off-label. Inclusion criteria for all of these EUAs require that patients be symptomatic with recent symptom onset, mostly within 5 days. Though I'll show you on the next slide what the differences are. Lab confirmation of infection. This has been a barrier, I know, for many patients because it's hard to get a test within 5 days. Hopefully that's going to improve in the next weeks. The patient needs to be at high risk for progression, as we discussed some of those factors. And then exclusion include patients who are hospitalized for COVID-19. This is an important distinction. We're seeing a lot of patients who may be hospitalized for something else but have COVID-19. They may still receive these therapies in the hospital. And then any patient who's on oxygen at baseline or who has a new oxygen requirement or a worsening baseline requirement would be excluded from use. You can move on to the next slide. So this slide is busy and more intended to be a reference, but I just wanted to show you the approved populations for each of these agents, the time frame in which the patient should be treated after symptom onset, the dosing, the route, and the duration of treatment. And I'll draw your attention to a couple of things. First of all, molnupiravir is only approved in those over 18 due to some demonstrated harm in development of bone and cartilage in fetal development and pediatric development. And that EUA specifically says greater than 18 and no other treatment options available. So this is definitely not first-line therapy. For most of these agents, the approval is within 5 days, though sotrovimab, though the study was for up to 5 days of symptoms, it is approved for use within 10 days of symptoms. And then the remdesivir study, again, was studied within 7 days of symptoms. Again, I want to emphasize that the sooner the better. So even if you have up until 10 days with sotrovimab, it is much better to give it early in the course. And then you can see the duration for the oral agents are both 5 days. The remdesivir is 3 days and sotrovimab is a one-time dose. You can move on to the next slide. So I wanted to cover some dosing considerations, and then we'll take a little bit of a deeper dive into the oral agents. So a couple things to be aware of. Nirmatrelvir, ritonavir requires dose adjustment for renal dysfunction. So if the estimated GFR is between 30 and 60, the nirmatrelvir gets cut in half. And then it's not recommended for those with an eGFR of less than 30. There's no adjustment for sotrovimab or molnupiravir for renal insufficiency. There is a theoretical risk for buildup of the adjuvant with IV remdesivir in patients with end-stage renal disease, but this is really thought to be theoretical and probably will not affect short courses. For those with hepatic insufficiency and really severe talking child's class C, both nirmatrelvir and remdesivir are not recommended. Sotrovimab is okay to give, as is molnupiravir. And then for drug-drug interactions, again, the nirmatrelvir is a really, really major problem for that drug. And there are some interactions also to be aware of with remdesivir. Sotrovimab, the main considerations have to do with hypersensitivity, and then the need to wait 90 days before vaccination due to a theoretical risk of impairing the immune response to vaccination. And we'll talk a little bit more about molnupiravir and fertility concerns on the next slides. So you can go ahead and move on. So this slide is really just to get you thinking about drug-drug interactions with nirmatrelvir and ritonavir. I've put in a link to the Liverpool interaction checker, which is really important. If you are going to prescribe this drug, you should check every drug on your patient's list. There are many, many interactions, and some of them are contraindications. Some of them require adjustment or holding of medications, and it can get complex, especially in transplant patients who are on immunosuppressants and anti-infectives that may really have problematic interactions. So I just wanted to really, you cannot memorize all the interactions, there's too many, but wanted to draw your attention to this fact that this is really important that you check this for your patients if you are going to prescribe. You can go on and move on to the next slide. You've probably heard, it's been in the news a lot, that there are some non-clinical findings of embryo fetal toxicity having to do with bone and cartilage formation with molnupiravir. So I have highlighted this one, that this is really not recommended for pregnant or lactating individuals. And then for females of childbearing potential, they need to be counseled to use contraception that's effective during treatment and 4 days after. And for males of reproductive potential who are sexually active with females of childbearing potential, they actually need to use contraception both during treatment and for 3 months after. So really important to be aware of this and include it in the conversations you have with your patients. A couple of other considerations with both nirmatrelvir, ritonavir, and remdesivir, they can decrease the efficacy of hormonal OCPs. So patients should be counseled to use alternative contraception methods. And the Society for Maternal Fetal Medicine has put out statements for all the drugs except for molnupiravir, really that these should not be withheld specifically for pregnancy lactation and are thought to be okay to use with a shared decision-making construct. I'm just going to end by talking a little bit more about some of the theoretical risks with molnupiravir. You can move on to the next slide, please. So coronaviruses use RNA-dependent RNA polymerases for replication and transcription of the genome, but they actually go back and proofread nucleotides. So typical agents that terminate the chains as this occurs actually are not effective in coronaviruses because of this proofreading step that's there. Remdesivir gets around this because it doesn't terminate the chain right away, but instead kind of stalls the polymerases down the line. Molnupiravir works a little bit different in that the nucleoside analog gets incorporated into the chain, and this leads to accumulation of virus mutations. And ultimately, the virus goes over this error threshold and will die. There have been some concerns raised that this may lead to treatment emergent changes in the spike protein that may then lead to decreased susceptibility to antibodies, either vaccine-induced innate antibodies or monoclonals, or to treatments. When the experts who've discussed this with the FDA and reviewed this, they felt like individual risk was quite low, but the public health risk is somewhat unknown at this point. Some experts have weighed in to say, the spike protein is going to develop mutations regardless. We're seeing that, and because molnupiravir decreases the viral load rapidly, it's not clear kind of how you're going to balance the increased mutations but decreasing viral load, whether that will really have an impact. But it is something to be aware of, potentially something to discuss with patients as you're considering this agent. You can move on to the next slide. So I just wanted to bring this all together and just put these agents side by side. We've talked about all of these pieces, but nirmatrelvir, ritonavir, again, NIH has prioritized this as kind of the first line agent. It is very efficacious, it's convenient. The really major downside is drug-drug interactions. For sotrovimab, it is really has excellent efficacy. The convenience factor is probably the major problem with this, and getting patients access to this drug can be challenging. For remdesivir, we saw really excellent efficacy, but the convenience is really a problem, and that's probably its major downfall. And then molnupiravir really falls down in efficacy and also the fertility and mutagenicity concerns that I mentioned. You can move on to the next slide. I've included some resources that I really like when looking through these treatments. We can move on to the next slide. And just wanted to end with some unanswered questions that I hope that will be answered in the upcoming months, including how are these going to perform head-to-head? Will there be a role for combination therapy as there are with many other antivirals? What is the benefit of these drugs in vaccinated and boosted individuals? We know them in unvaccinated individuals. What is the benefit in the Omicron variant and other future variants? Do these drugs prevent long COVID? What is the benefit in lower risk patients, and will resistance emerge? So I've included a summary of the points that we've made. I won't belabor that, but would love to stop and take questions. It looks like we have a few minutes left.
Sarah, thank you so much. I feel much more educated, and I'm sure everyone does. That was a wonderful summary. I think Erica is going to be able to join us again, but I'll go ahead and start with a question for you. We did have a question from the audience, and as a pediatrician, I wondered myself, where are we progressing towards oral medications or any of these outpatient therapeutics for children under 12?
Yeah, that's a great question. And I do not know where we are in the trials of patients under 12 years old. I'm sorry, I don't have that answer at my fingertips. My guess is that those are going to be slow to come because it's hard to get studies in pediatric patients. Yeah.
Okay, great. And then talk to us about the cost of all these therapeutics. Is it just enormous?
Well, the cost to patients for the therapeutics is zero for the actual therapeutics. Patients' insurance may be billed for the administration of the injectable agents. And then for remdesivir, because it is now FDA approved, that may be billed to insurance. And there was some recent changes to the codes to allow for billing for outpatient use. So there's the trying to get the outpatient use set up is really has a lot of barriers, but that will hopefully open up some ability for centers to be able to offer this to very high risk patients.
Great. Erica, let me just pivot to you quickly. You talked a lot about these very small numbers, unfortunately, of these therapeutics that we have right now, but I know how difficult distribution and rollout can be. We saw that in vaccines. Are we using our allocation?
These are literally just in the last couple weeks, but yeah, I think the first allocations from January 3rd have been distributed to the local level. And there is a similar but different analogous system as far as inventory, and the places that receive these are supposed to enter the utilization. I admit, I don't know that we've taken a look yet, but I think it's not currently a requirement. Like vaccines, it may become a requirement to get more to actually be able to enter that information. But it's so little, and just talking to, clinicians, I would be shocked if we're not using it, because it is, everybody does really, for all the reasons we're talking about today, I think it is getting used.
Okay, great. And just a second, Erica, to kind of pivot away from therapeutics, there's lots of speculation. We've all watched the hopeful curve in South Africa where Omicron seems to have peaked and is coming down. And, how in that sort of timeline are you willing to, I ask you questions like this every time, are you willing to hazard a guess about when and if we will see a downturn if it turns out to be analogous to South Africa?
Yeah, the crystal ball questions, and what I always say to you, I think is, and I just continue to learn, not to make predictions with this virus, but I think, I think we're hopeful that that's going to be the case. I think looking at the UK and Denmark and others, I'm not sure it's not coming down as quickly, and even South Africa isn't as quickly as some have said. And I will also just caution people to know that with Delta, when it was in India and first hitting there, it was a fast rise and fall, but we didn't see the same kind of quick fall. But we are hopeful. I mean, there are a lot of other reasons this particular variant might move faster, though, as far as just a short incubation period. It is so transmissible that we are all being exposed. I think, we all of us have anecdotal stories, I know, of people that we're close to who have been extremely careful and still been infected. So anyway, long way of saying, I'm not sure, but hopefully, hopefully it will be shorter than previous surges.
Okay, well, thank you for taking my my crystal ball questions every time. Sarah, let me ask you a question, again, a bit of a crystal ball one, but how are we supposed to think about these therapeutics when timely and rapid testing isn't really available? Do you imagine a time when we have more supply and we might begin to treat empirically like we often do for Tamiflu with a presumptive diagnosis of influenza?
Yeah, I've been asked this by our clinicians for sure. The EUAs specify that the patient must have a positive test. So for right now, we are required to follow the EUA to the word. So I've been encouraging our immunocompromised people who care for our immunocompromised patients and patients at highest risk to make sure their patients really have an action plan in place so that if they do develop symptoms, that they know how to get a test quickly and know how to contact their providers for treatment. But the more barriers we have to each of those, the more there's going to be a delay. And I think the optimal would be having a place where patients can go get a point of care test with a backup PCR just in case, and have access to therapies right away. And hopefully those will increase the number of places that really have this rapid linkage to care, will increase to be able to get effective therapies into the right hands.
Okay, great. I'd love to hear from both of you about this one. And this is one of those things that people are reading in the media, and so patients are bringing into physician's office. So when we're testing, should we add a throat swab these days? There's sort of been this suggestion of that. Again, questions I know you love, but this is what we're hearing from our patients. Sarah, do you have a comment on that?
We do throat swabs as part of our swabbing. It increases the sensitivity a little bit of the testing. I think there's a balance between what is pragmatic and what is achievable, and what is kind of the optimal 100% sensitivity. And I think if we are getting tests that detect highly infectious, virus, that's probably the most important thing. Be curious to hear Dr. Pun's thoughts.
Yeah, it's another one of these. I feel like there's a lot of anecdotal emerging data. There's that one study with the saliva PCR, and I feel like we're a little slow on getting our data to, because the FDA is very firm yet again, on what, you shouldn't be, this isn't approved to even do a throat specimen collection. We are trying to see within the state if there are some of our cohorts that we can do kind of a head-to-head to compare and just get some data in California, but we don't have it yet. And I do, I agree with Dr. Dornberg. It's sort of, we're always trying to balance this, what's the most practical, but as people hear more and more anecdotally, and there are other examples with certain other diseases where sometimes and early on where the throat PCR was a little more sensitive. So yeah, but I wish, it's, again, these tests are not even sort of technically approved. And so I'm hoping that we can catch up and move the bureaucracy quickly as well once we get good data to see what really is the best sensitive. But I also agree, this is such an infectious virus that hopefully we are catching a lot of the most infectious patients still with our current testing.
Right.
And great. I should clarify that we're doing oropharyngeal and nasal swabs, not true throat swabs.
Yeah. Okay.
Yeah.
That's helpful. Thank you. And that application of data to all of these questions is so important and so hard because we have a delay when something's so fast moving. But I'm glad to hear that this state, I'm sure we all are, is beginning to do their own look at that data. We have just a couple more minutes, and maybe Dr. Pun, you can comment on sort of the move towards maybe a fourth booster, and if there's any conversation about that. I know, again, these are national decisions first, but what your thoughts are on that.
Yeah, I mean, we're watching kind of the global and national conversations very closely. I think, I think there's a lot of just sort of discussion as well on, I think our goals for vaccination are to prevent hospitalizations and deaths, right? And so I think we are showing over and over again, thankfully, that they're doing that work. And we're seeing something like Omicron where, yes, there's lower severity, but it's still having this huge impact on all of us, as I was illustrating. So, how much extra sort of, are we going to get from additional boosters? Because I think there's a lot of good evidence about our T-cell immunity, again, keeping us out of hospitals with even our current regimens. So, I think we will stay tuned as well. And, we are lucky enough to have our Western State Scientific Safety Advisory Group as well. And a lot of those experts are on these national panels. So watching it closely is what I'll say.
Amazing. Well, I know that we're all super grateful to have both of you as experts here with us today, thinking every day about this with such sort of wisdom in the face of lots of excitement and emotion. So wishing everyone on the call a healthy and safe January. We will be back on the second Tuesday in February with another one of these sessions, and I know that there will be lots more information to present at that time. And so please mark your calendars for that. Reminder that you'll be sent a survey if you'd like to get CME, and we'll send you your certificates for that. And I just want to send, again, a huge thank you to Dr. Dornberg and Dr. Pond for your presentations today.
Thanks for having me. Take care.
Thank you, everyone. Take care.